Good morning, Colorado. What a joy it is to spend some time with you this morning. So, welcome to the Rural Health Transformation Program webinar, co-hosted by Healthcare Policy and Financing and the Colorado Rural Health Center. Let's go to the next slide, Kelly. So today we're going to spend about 90 minutes together. We're going to start off with a welcome and an agenda. As we move through the agenda, we are going to work really hard to explain the Rural Health Transformation Program application that we submitted, the scoring and terms, and in essence, help everybody understand why the content is what it is. We're also going to go through in detail some of the initiatives and the performance metrics and implementation timelines within that application. We're going to go through a budget overview and the CMS review process and timelines. We're also going to go through some of the processes for funding disbursements and stakeholder engagement and advisory committees as follow-up steps. And we'll spend some time on Q&A. Now, just to clarify a few things in here. For example, as we go through the budget overview, you'll see that we're using a template that was required as part of the application. And you'll see that template adds up to $1 billion over 5 years, $200 million a year. As an example, in the application that we submitted, that doesn't mean that's the amount of money we're going to get. It means that's the template that the application required. Another example of things that'll provide really good learnings for you today is there are terms that might not be familiar to you and I and those in healthcare as we would use them in our typical conversation. So an example would be when CMS uses the term networks, they really are referring to what you and I might call provider partnerships or hospital partnerships. And so as we walk through this agenda, we're really trying to help you understand the terminology that CMS uses so that you have a better clarity on the information that we're reviewing. Now let's go to the next slide and talk about some presenters and then logistics. So also presenting with me today is Michelle Mills, the CEO of the Colorado Rural Health Center, and also the board chair for 2025 for the National Rural Health Association. So we're very excited to have our co-host with us today and the expertise and authorities and influence at that high level here in Colorado. Cami Tam Singh is our hospital transformation and value-based project manager here at HCPF. And Laura Segrest is an expert consultant who's been with us all along the way as part of Government Performance Solutions, and other consultants with Government Performance Solutions are also in the background and been helping all of us submit the applications and will continue as an expert partner with us. For those, when the presenters first present, we've asked them to just share a little bit of their background in about 30 seconds. I'm going to do that now. So Kim Bimsteffer, the CEO of Health First Colorado, that's the Colorado Medicaid program, and the Executive Director for Healthcare Policy and Financing. About 37 years in healthcare, 8 years in this position here in public programs, and previous to that, nearly all commercial time in leadership. By next March, about 30 years in leadership, CEO, general manager, market president, and regional vice president. Let's go to the next slide, please. So for the logistics, we really want to hear your questions. Those questions will not only help to answer them at the end of the session, and we'll leave about 20 minutes for questions. So we'll have that time, but it also helps us inform what the next webinar might look like, and whether that's in January, what it might include, the areas that are still unclear for you. So it'll help us inform next steps. Presentations, links, and materials will be posted in the chat. Otherwise, the chat's closed. We use that to communicate behind the scenes to make sure today's webinar goes smoothly. In the presentations, you'll see a narrative for the application submitted by Colorado. And as Cami's going through and describing and helping people understand what are the initiatives inside the application, you'll see page numbers. Page numbers are referring to pages within that narrative of the application submitted by Colorado. Materials will also be posted on HCPF's Rural Health Transformation website. We have Spanish as well as American Sign Language interpreter services, as you can see right now going on. They're available. You can also click on the toolbar for more supports there. And please utilize the website there that's on the screen for future inquiries. That's really important that we make sure we answer your questions timely after this webinar. And I really want to thank you all for your engagement today. This has been a sprint for sure, and you've been with us along the way. We truly appreciate that. Let's go to the next slide, please. So Michelle and I are going to start with some introductory comments, and I will do that and then turn it over to Michelle. So one of the first things I want to say is thank you not just for your engagement today, but thank you for the time that you've put in coming up to this point, helping us figure out what needed to go into this application, making sure your voice was heard, asking the questions that helped us make sure that we could get you the information of how this was going to work with CMS, timeframes we were under. And I also want to recognize that the monies that we're talking about here, again, probably a minimum of 100 million a year for 5 years, so 500 million, maybe 150% of that, so maybe 750 million. I have some high hopes for this, but I want to recognize that these numbers are very similar to the amount of money we used and are using to transform the behavioral health system. They're actually a little higher than that. And these numbers that we're talking about are higher than the numbers that we've been using to transform the systems that support people with disabilities, which is part of the DNA of healthcare policy and financing. But the amount of time we were all given to actually come up with this approach in the application was nowhere near the time we had to do the other huge projects that are of this level. And so I want to thank you for everybody trying to figure this out as quickly as we can. At the same time, I'm asking for a little bit of grace because the CMS has not done this before in this way for rural transformation. They haven't done applications in this way. They haven't made decisions in this way, and they haven't negotiated the terms of how this will work state by state before, nor have we. So all of us together in collaboration with the Colorado Rural Health Center, Michelle and her expert staff, and all of us together, we're doing something for the first time, including help getting us all through this process. So thank you very much in advance for navigating the next steps with us as well, which are a new frontier for all of us. Michelle, turn it over to you.
Yeah, thanks so much, Kim. And hi, everyone. I'm Michelle Mills, and I'm the CEO at the Colorado Rural Health Center. We're the nonprofit State Office of Rural Health and Rural Health Association in Colorado. That's fairly unique. There's only 3 of us that exist in this nonprofit status across the United States. Michigan and South Carolina are the other 2 states. I also have the honor of serving as the president of the National Rural Health Association for 2025. So that's really offered a lot of unique opportunities to be able to meet and help influence some decisions that are being made for rural health. So very honored to serve in that way. I have about 33 years in rural health experience. I have 18 years that I spent at the Quality Improvement Organization, and I was making kind of a little joke when we were practicing these slides that when I left that job and came to the Rural Health Center, we were working on CMS contracts, and when I left, I was like, oh my gosh, no, I'm never working on another CMS contract again because it's so hard. And look at, here we are today working, so never say never. And I've been at the Rural Health Center for 16 years now in January, so very honored to serve in this role. Like Kim said, thank you all really for being here, and want to say a huge thanks to the governor's office and to you, Kim, and your team for allowing us the collaboration to work on this. It has been so hard. I don't think, we've ever put something together for this amount of money in this short period of time. So it's been really a little crazy. And as you know, these rural transformation funds were put into HR 1 at the very last minute. And so nobody knew. It was really unexpected. And we want to definitely recognize that, this in no way is going to cover the loss in the Medicaid cuts that are being proposed. But what we do hope this will do for us is really help us prepare for the future, help us figure out kind of the best ways to sustain rural healthcare in our rural communities. I want to just say that it's really vitally important that we get this right. Rural hospitals in particular are at risk. We have 21 rural hospitals out of the 43 operating in the red right now. And those are the major employer within our rural communities. And they bring about $60 billion of economic value yearly to their communities. So thanks again for attending.
And Michelle, before you go into the next slide, I'm going to ask Julieta, our Spanish interpreter, to just give some in Spanish directions to those who want to use that avenue.
Buenas tardes, mi nombre es Julieta y brindaré servicio de interpretación en español. En un momento este servicio estará activado. Para escuchar la interpretación en vivo en español del evento de hoy, seleccione el módulo Interpretaciones en la barra de herramientas de Zoom y luego seleccione Español. Tendrá la opción de seleccionar Silenciar audio original si desea solo escuchar español. Este módulo de interpretación se activará momentáneamente.
Thank you. Let's go to the next slide. Michelle, over to you.
Yeah, great. Well, thanks. So like Kim said, we are going to go through and review the application today, hopefully making clear understanding to you all on, what we submitted, kind of why we submitted it, what the requirements were and what some of the limitations were for this grant that was submitted on November 5th. So next slide, please. So the HR1 put in $50 billion. Yes, that's 50 billion with a B. So meaning that there's about $10 billion of funding available each year if all the monies are split equally. There's two parts of these funding. So the first 25 billion is supposed to be distributed equally among all approved states. And I'll emphasize that approved is kind of the key word here. So if that happens, that would be the half of the monies available for that. Then there was a second half of money. So that was the second half of that 200 billion that we applied for. And so this is really based on factors that are like the rural population, how many rural healthcare facilities, what the sustainability of those facilities are. And most importantly, this is really based on CMS's discretion for who receives the second portion of that funding. And so, like I said, on November 5th, we submitted, all 50 states did submit for this grant. So that's great because we know everybody is really in need of those funds. And then CMS is supposed to announce the awards by the end of December this year. So hopefully, fingers crossed, we will hear and we will receive the most amount of funding possible. Next slide, please. So CMS guidelines for this application. So I was making a joke that I didn't want to work on CMS grant again because they're really hard. And so CMS had some strategic goals set out, which are Make Rural America Healthy Again, or MAHA, as you may have heard it referred to, sustainable access, workforce development, innovative care, and tech innovation. So there's a lot of restrictions and a lot of tight timelines and limitations that come along with this funding, including there's only a finite number of entities that are eligible for this funding. So all the funding is to go to rural with the exception of tribes, which are also included in urban. And so that's rural hospitals, including critical access hospitals, soul community hospitals, like I mentioned, tribes, community health centers, which includes federally qualified health centers, federally qualified lookalikes, which is essentially a federally qualified health center that does not receive the Section 330 funding, designated rural health clinics, and other clinics that are receiving Section 330 funding. Behavioral health providers are also included, as well as EMS is included in this. Next slide, please. All right, so limitations and restrictions. So pre-award costs. So that essentially means all the time that we spent building this application can essentially cannot be included as a part of this funding. You also can't use this to meet matching requirements for any other federal funding or local entities. And then funding for provider payments, which I know is a disappointment for folks because a lot of people that we heard from really wanted a lot of the money to go to provider payments, and that essentially cannot exceed 15% of the total amount of award from CMS. Next slide, please. So equally disappointing is folks were hoping to use some of this funding for upgrading their EMRs, but CMS came out and said that there's no more than 5% of the funding yearly could be used towards replacement of an EMR. And that's really because back in 2010, there was meaningful use where CMS had paid for that money. I will say equally, no new construction. This also was a huge disappointment for our folks as well, because we have a lot of aging plants that were built, in the 50s and the 60s that are needing replacement, and those funds are hard to find. So unfortunately, these funds cannot be used for new construction as well. And then you cannot use funds for supplanting or duplication of existing state, local, tribal, or private fundings or infrastructure services, such as staff salaries as well. I will say that there's links in these slides here. Definitely use them. It will take you out to HCPF's website if you want to see the whole list of funding limitations. And I will now turn it over to Laura. So thanks, Laura.
Thanks, Michelle. Next slide, please. I'm Laura Sigrist, partner with Government Performance Solutions, and we have had the privilege of working with the Department of Healthcare Policy and Financing, other healthcare providers, and communities across Colorado for more than a decade. And we are, as Kim mentioned early on this morning, the Colorado-based public service sector vendor supporting the Rural Health Transformation Program. Thanks for having us here today. I want to talk a little bit about the scoring factors and what we know from CMS, what they'll be evaluating for Colorado's application. So as the application has been developed, we considered each one of these scoring factors along the way. We know that Colorado needed to put forward the most competitive application possible. And when we think about the specific scoring factors, it's important to know that some of these components are data-driven, so they're hard factual pieces of information, and others are going to be merit-based scores that CMS will deliver for us. So let's talk about those categories. The first is data-driven. CMS outlined 9 distinct categories, and they're going to award points in each one of those categories based on state-specific statistics, and they'll compare Colorado's score against all of the other scores of the states in the country who have successful applications. Those things include rural population, square mileage, number of rural health facilities, the amount of uncompensated care, and the level of disproportionate share payments, among other factors. The second category is the initiative-based factors. There were 10 distinct components that CMS outlined, And these are going to be the merit-based reviewed and scored components. And you'll see, we'll talk a lot more about our specific initiatives. But the things that CMS is going to looking for are things like clinical infrastructure, initiatives that support partnerships, emergency medical services, workforce, recruitment, development, remote care, data infrastructure, and consumer-facing technology. The last factor that CMS has outlined are what they're calling state policy actions. There are 8 distinct factors here. And in a lot of cases, CMS has already assigned points based on third-party reviews and reports. So what they're looking for are current state policy and programs, as well as those that the state has committed to implementing by the end of 2027. Some examples of those include SNAP waivers, continuing medical education requirements for nutrition, certain licensure compacts, scope of practice, and other factors. Next slide, please. Along with those scoring factors, it's really important that we all recognize that our application needs to be written for the audience that will be reviewing Colorado against every other state. So what we know so far is that the CMS appointed reviewers who will be scoring our application are not necessarily going to be experts in healthcare. They may not be familiar with the specific language of healthcare. And likely, they're not going to be experts or potentially even familiar with the geographic, demographic, economic, and other factors that make Colorado's health landscape so unique. We do know that the reviewers will be specifically looking to see how we've complied with rules for submission in both substance and in form. Next slide, please. I'll turn it over now to Cami to walk us through the specific components of Colorado's application.
Thank you, Laura. Hi, everyone. Thank you for joining us today. I'm Cami Tamsing. I am the manager of the Hospital Transformation and Value-Based Projects team, and I also led this project for HCPF. So thank you for joining us today. We're going to review our application, which is why everyone is here today. So we will go in depth here. So next slide. All right, so how did we start out our process? So as Michelle stated, we and Kim as well, we had a very short window for what should be given months to prepare for and write. So we were also given 11 permissible uses from CMS to choose from. Each state is required to choose at least 3. So taking all of that into account, also keep in mind that CMS is looking for applications that are very transformative with the ability to be sustainable. So as we are reviewing the permissible uses, we had to take all of that into consideration so we get an approved application. We did this by holding several stakeholder engagements and along with a lot of discussion and what are our capabilities and needs for our rural communities. On the left-hand side of this slide, you will see the 6 permissible uses that reflect the priorities of Colorado. You'll see those listed, and we'll go in depth as we move along the slide. On the right-hand side, you can see our stakeholder engagement. With such a short amount of time, we were able to accomplish quite a bit. With the rural health care providers, the Rural Health Center was able to meet with over 50 rural health care providers to consult in the development. HCPF and the Rural Health Center held formal stakeholder sessions in September and October to discuss things like the CMS strategic goals that we do have to align with, our permissible use options, and that long list of restrictions that we do have. We had over 200 stakeholder attendees for each session, so it was quite successful. A full list of these permissible uses will be found in the appendix at the end of this slide deck. Next slide. All right, so this slide is a very busy slide, so bear with me here. We're going to go through it. On the very left-hand column, these are those CMS strategic goals. You'll see this throughout the application. It is vital that we align all of our initiatives and our permissible uses to these goals. They do interconnect. They don't all have to align with each one, but we do have to make sure that we have measurable outcomes that address at least one for each of these 5 areas. The next column over, these are our Colorado initiatives. We'll explain this in more detail in the later slides. However, I do want to highlight here, under sustainable access, we do have language such as rural health networks, as Kim stated before. We are referring to those collaborative agreements, collaborative partnerships. That is the language that CMS is looking for in the application. And this is where we are going to highlight what we are able to measure. And we also worked very hard to align with our current quality programs. So that way we are able to reduce administrative burden where we're able to without being duplicative and able to follow what CMS is requiring. So the next column over, Colorado's permissible use of funds. So these are those 6 areas. We have 5 here, but they do interconnect. You'll see how they kind of go together as we move along. And then our outputs. That is what CMS is looking for, and we were required to have that. Right, next slide. All right, here's our big one, make rural America healthy again. So transform rural care. So you'll see a page number here, as Kim mentioned earlier. This is a part of our project narrative that can be found on our website. If you would like more details for this particular initiative, this is where you can find it. And this supports our educational purposes for disease prevention, care coordination services for cardiovascular disease, hypertension, obesity, and other high priority chronic conditions. We have potential activities that we can implement, and those are listed below. We were required to identify areas that we already have programs so that we do not duplicate funding there. So you will see ways that we did that. We are able to align to gather data. However, if funding is already going towards a program already, we are not able to then provide this grant funds for those areas. We are able to launch new initiatives and support in other ways. So you'll see this throughout. So these are potential. We are going to be working with CMS post-award on a lot of different things. So not everything is going to be set in stone. All right, next slide. So Initiative 2 also aligns with MAHA. Build data infrastructure, again, found on page 27. So this is going to strengthen our data systems, performance monitoring, and evaluation to ensure that we're on track for chronic disease prevention and management programs. This is going to be a big initiative for us, for Colorado, and in our rural communities. And you'll see we do have supports already as far as the rural COSHI hubs, the Colorado Social Health Information Exchange, that is provided by our Office of eHealth Innovation. So where we are able to align, we really did heavily to, again, reduce that administrative burden. Right, next slide. All right, Initiative 7. So expand preventative care. So this initiative, we're identifying the clinical workforce that's needed in each area, the capacity to deliver those preventative services that are vital, and the procedures in the rural and frontier communities that are needed. So again, we outline the potential activities. We'll emphasize that as we continue, because this is subject to change based on what CMS and those negotiations look like post-award. So some of those do include training for rural providers to expand skills. We really want to focus on the homegrown workforce. Where can we support the workforce that we have already and expand those skills? and also providing continuing education scholarships for rural clinicians and the care team members. That's important for us as well. You'll see that throughout. Right, next slide. So one of the requirements also is to provide a timeline for when each of these metrics or measurable outcomes, as we outlined here, when could we potentially implement? And I say potential here because this is an area that CMS is going to negotiate with us. There are big areas where we can do that. Budget distribution, and right here, implementing programs and those measurable outcomes. We do want to show that we can have measurable outcomes right up front. CMS is going to want to look for that, as well as our more long-term programs that will last throughout. So you'll see different timings here, and that's on purpose to meet CMS's requirements and what they're really looking for an approved application. So right now for MAHA, or Make Rural America Healthy Again, we have these five metrics that align. Right, next slide. Sustainable access. So this is really to build and connect Colorado's rural health networks. So again, and the application states networks, this is not a technology-based one. This is a really collaborative agreement, collaborative rural health networks that you're building together, whether it's a rural health clinic, a critical access hospital, whatever the combination needs to be successful. This is really to build the system for regional health networks and developing a centralized data tracking system to connect hospitals, clinics, local public health agencies, and community partners. This is going to be important for us to improve our access, the quality, and the long-term system resilience. We need this for the sustainability piece. This is going to be big for Colorado. So our potential activities and areas that we will have available, building those regional health networks, that's going to be important for patient care. We will have regional health data dashboards, and we will also be supporting our tribal participation in creating their own rural health networks. That is going to be important. We are going to be working alongside our tribes each step of the way as we move forward. Right, next slide. All right, here, initiative 4 are strengthening our rural care delivery system. So again, what does this mean? This is going to strengthen, modernize, and transform our rural care delivery systems really across Colorado. And that's not necessarily just hospitals. It's going to be improving EMS coverage, expanding care coordination, and supporting clinical integration among hospitals, but also clinics and other local health partners as identified by need. So again, we do have potential activities below. Our emergency medical services transport, we want to improve that, develop new coverage models to sustain and or expand the rural health emergency capacity. Colorado has a need and opportunity here. So as we're looking at our activities and what we're capable of, we do want to see what our major opportunities or gaps are for each region. So we also have funding for regional coordination of EMS services as a potential option and supporting those collaborative care networks. Right, next slide. Another initiative for sustainable access is Initiative 5. So we want to sustain hospital operations. Again, more information on page 31 here. This initiative really supports the long-term stability, and that is what CMS is looking for. How can we sustain things? So the operational capacity and regulatory readiness of rural hospitals across Colorado. This is going to help support our expansion and coordination of essential services and help modernize operations while staying compliant with emergency regulatory and payment reforms. As we pick initiatives and move forward with them. We are, of course, very aware of not duplicating reimbursable services and providing direct funding of clinical services. That is going to be something we have to be in compliance for with CMS to continue funding. Again, potential activities, we're not locked in here, so I do want to emphasize this. We are going to continue to work with CMS post-award on this, but we do have to provide sort of a guideline here. So you'll see that. So procuring technical assistance, targeted operational support to help rural hospitals to make sure that we realign or sustain those essential service lines. Examples of those are primary care, emergency, maternal and child health, and behavioral health are going to be very important here. All right, next slide. So again, here is our timeline for the metrics or the measurable outcomes that align with sustainable access. We have 5 of them here. And I won't go into more detail, as you can kind of see our timeline, because again, we are going to be negotiating with CMS on the timing of each one of these. Next slide. Workforce development. This was definitely a big need, not only in Colorado, but I believe most states across the United States. Workforce development in rural and frontier areas is going to be a big one. I've seen it in other applications as well. This is a high priority to strengthen and expand our workforce. So what we're approaching here is really focusing on our homegrown workforce. We want to support who we already have, offer other certifications or skill building if they would like to expand skills and enter into a different part of healthcare here. We want to provide that and support it, as well as offering credentialing, other certifications, education opportunities. So this initiative will really strengthen Colorado's rural health workforce by expanding the access to those items. And those are just examples. Again, the funding will also be used to attract and train and cross-train, like I had stated before, local essential providers. So not only physicians, but also nurses, pharmacists, behavioral health clinicians, health workers, technicians, and many others. All right. Yes, yes, I see all the thumbs up. This is going to be a big initiative for us. It's vital. All right. So we will move on to the next slide, please. All right, so continuing on with workforce development is Initiative 8. So this is state and local coordination. And this will focus on enhancing the coordination, communication, and alignment between not only the state regional areas, but our local health entities. This is going to be important to be effective and have implementation and prevention for the workforce programs. So we'll invest in leadership staffing, technical assistance, and training to strengthen those collaborative governances. And this will help us sustain post-award. So this is going to be very important. Again, potential activities, develop and implementing interagency coordination for various departments, public health agencies, community organizations, also formalizing those collaboration practices and network level outcomes. So this is going to be all important. It all supports one another. You'll kind of see how they all work together. Right, next slide. All right, here is our timeline and our implementation timeline for our workforce development. We have 4 metrics here, or measurable outcomes on the side, as we just went through. So you kind of see the we have quite a bit of initial onset here that we're able to do right away, and that's going to be important for us, along with some more long-term initiatives. All right. So I'm going to move on to the next slide. So innovative care. So I will say innovative care is a big one for us. Colorado as a state is actually leading here. Even in the application process, Colorado was highlighted for our hospital transformation program, as well as some other programs that we already have going. So it was important that we discussed those programs we currently have, including our Accountable Care Collaborative and others as well. This is how we can align with those programs without duplicating funding, but we can use data we already are receiving to help support and reduce that administrative burden. So you'll see this throughout. So this initiative, we are going to do some research, design, and pilot, and ultimately scale those value-based care models, but tailored for the rural providers and hospitals. So this will assess the feasibility of our shared savings, bundle payments, and other approaches. And it all, again, is going to support all the other initiatives that we're discussing here today. We were very aware of the programs that we're already doing. In fact, that is a requirement for the application to discuss those and ensure that we are staying in alignment as we move this program forward and not causing undue, burden where not needed. So you'll see that. So potential activities, will include collaborating. Again, you'll see that quite a bit. We all need to work together to make this successful. We need to collaborate with rural health clinics, hospitals, and regional accountable entities to implement all scalable and value-based frameworks. So one area that was definitely highlighted in the application were any ACO infrastructures, and Colorado is lucky enough to have that in place. We are also exploring clinically integrated networks and also supporting rural population health priorities and community needs. We really want to know what each region needs. So that's going to be important as we move forward and for later on post-award. We'll get to that later. But we need to assess our action plans through an ACO-like infrastructure. Again, CMS did highlight that as a priority. So we are focusing on that. And of course, by HCPF under phase 3 of the Accountable Care Collaborative, we do have that effective July 1st of this year. All right, next slide. Okay, here is our innovative care plan. We have 4 measurable outcomes here or metrics. You'll see those. A lot of these we can launch or already receive data because we already have them right now. And that is very important and actually an advantage for Colorado and makes us a very strong application. We are ahead of the game here in our quality programs, which is amazing. Everyone has done fantastic work in this space. We also have areas that we can continue this work as we go. So you'll see here, where we have potential, where we already can utilize the data that we have, and sort of the timeline. All right, next slide. All right, tech innovation. So this is also a big priority area for CMS. They outlined all 5, but there are a few that stand out. Initiative 10, so expand our rural telehealth and technology integration. So again, I will reiterate, as we moved forward and discussed our permissible uses and how we're going to align them, what we can have measurable outcomes, it's important that we also address what CMS is looking for so we get that approved application. That's going to be important for us, of course. So this one is definitely important, as well as all the others. So this will strengthen and expand our rural health system participation in the use of technology-enabled prevention, monitoring, and care delivery. A few examples of that include telehealth or e-consults, remote patient monitoring, And this initiative will also equip rural providers and other agencies with those tools and technical support that's necessary to be successful in this area. So other potential activities that we have provided is, conduct a statewide technology readiness assessment if we need to. What are the needs in this area? We're going to support local health organizations to expand mobile health programs across rural regions, This actually was also highlighted as an area that CMS is looking for. So we can allow for scaling, staffing, and compensation of the workforce. And also, we will be having those integrated dashboards and networks to help maintain and be successful in this area. Right? Next slide. All right, again, here is our fifth and final, tech innovation timeline. Again, subject to change based on negotiations with CMS post-award. But these are the 5 metrics that we have that we're ready to launch, or also have already set up and ready to go, sort of our timeline when that could be accomplished. So again, this is not set in stone. We will be negotiating with CMS on our budget distribution and our timeline for implementing all of these areas that I just discussed. So this is going to be very important to keep in mind as this moves forward. There are a lot of unknowns that we still have that CMS has not provided for us, and they won't probably until we're awarded and assigned somebody from CMS to work with directly. So with that being said, I'm going to turn it over to Kim to discuss our budget distribution.
Thank you, Cami. That was a lot, and you covered it well. We really appreciate all the time that you've put into this. And audience, when Cami says we, I mean the royal we, all of us, the state of Colorado, all the providers on the phone, everybody submitting their opinions on this work. It's the royal we trying to bring this money home to Colorado. So relative to money, as I said in my introductory comments, the application is complicated. It also had very specific guidelines that you needed to follow. One of them was filling out a budget template that assumed for all evaluations with all states against each other, $200 million a year for 5 years, adding up to $1 billion there down at the bottom. We shouldn't rely on or assume that we'll get $1 billion, but we can cross our fingers and do it just as we've done up to this point, the best we can to bring as much money back to Colorado. So what went into crafting this budget? Well, Cami reviewed and Michelle reviewed and Laura reviewed some of the restrictions that we had. So we needed to study all the monies we're already getting, needed to remove them as possibilities. So if we really had tons of grants already coming in from the Fed, it limited some of the things that we could do in certain areas. We also listened acutely to all of your feedback as stakeholders. So navigating within the restrictions of CMS's application, listening to you, but also listening to all the webinars that CMS put on, because they were giving us hints of things that were very important. And the first part of this application is to really get as much money back into Colorado as we could. And then, even though things might have been really important to us and they're in the application, that might not be what CMS agrees they want us to do with that money. So we needed to really stay in compliance with the rules, regs, and what they said was going to be very important in the evaluation. So this reflects all of that amazing input. And thank you again for your engagement yesterday in helping us build this, and tomorrow in helping us get to the next steps. And so if you look across each of the areas that Cami went through on the goals, you can see make rural America healthy again. We all know that that's a very important a goal of the federal government, the current administration at the Fed. So 229 million over that 5-year period, sustainable access at 100 million or 106, workforce development at about 150, innovative care at 230, tech innovation at 255 million, and then our administration at less than $30 million. And I want to underscore, let's go to the next slide, please. I want to underscore CMS allowed 10% for administration. to go to the organization that is doing that administration, which is healthcare policy and financing. And we're less than 3%. And so we have some good experience in doing this through the ARPA grants and other grants that came from the federal government. We know what it takes in order to stay in compliance. One of the most important things that we all got to focus on is making sure we have the right resources, that we can track all of those metrics, that we're achieving those metrics, that we have some insights before we're getting behind, to make sure that we're supporting and everybody supporting the organizations who signed up for the grants and who made commitments to achieve those metrics. Because if we don't achieve the metrics, the money gets clawed back. And if we don't spend the money in the period of time that it's allocated for, say year 1, year 2, they don't let you roll it forward. So the monitoring that we're going to have to do is going to be pretty intense, and that's going to require resources. But again, we're pretty good at that. We can share resources around HCPF. We've got very good vendor partners. You're meeting one today, and Laura. And we have the resources to be able to surround this. We don't have to start from ground zero. So we're proud of that less than 3%. But boy, we're going to have to do a lot of work together to make that 3% or less than 3% sing in order to meet all the demands of CMS to hit that objective, which is don't allow the clawbacks because we didn't follow one of the rules. We didn't monitor appropriately. We didn't report appropriately. So we're going to mitigate all that risk by doing this right, but try to do it as efficiently as possible so that we have as much money as we can, what I call out in the field, right? Out where we need it, in the hands of the providers and partners who submit the application. So you can see the percents there in that pie chart and that low 2.98% admin. Let's go to the next slide, please. So in addition to the admin, we want to make sure that we hit all those staffing requirements in order to make sure we mitigate any clawbacks, that we stay in compliance, that we submit the right data and reporting, and that we get the funds distributed to all of you who are very eager to submit applications and get the money into the project work that's important to you and your community. I can't underscore enough about the clawbacks. Boy, do we not want that to happen. So thank you in advance for everybody realizing when you submit an application, boy, do you need to put the resources around it on your own side to make sure you comply with the goals that you're signing up for, because those metrics that Cami just went through must be achieved. We are forbidden to use any other funding sources to support the staff, so we need to live within that 2.98% that we have. We can obviously use the infrastructure that we already have. And all states must be in compliance with any audits. So as we're learning with lots that we do with the federal government, documentation is an absolute mandate, because they will come in and audit everything that we've done everywhere where every dime went. And we've got to be able to account for all of that. We're ready for that for all the ARPA funding and all the other grants that we've accepted, and we're ready for that as a standard. And we must comply, all states, with all of the reports that are required. Let's go to the next slide, please. Okay, I will turn this over to the next speaker.
Thanks, Kim.
Laura.
This is Laura. Thanks, Kim. Yeah, so just wanted to highlight again a couple of the key deadlines and some pieces of information that we know from CMS. We've seen some questions come up over the last couple of months around when will we know, what will we know, when will the dollars be distributed. So we're going to share with you exactly what Colorado knows as of today. So a couple of things to highlight here. In terms of the CMS review process, Colorado submitted our application just ahead of the CMS deadline in early November, as Kim and Michelle alluded to. Couldn't have done it without you, with this incredibly tight turnaround and a massive lift. So again, another moment of gratitude for that. So we're currently in this process where CMS is looking at each state's application, determining who meets the qualifications, sending back questions, and potentially asking for more information. As of yesterday, Colorado has not received questions, but we have heard that states are starting to get some feedback from CMS, so we'll be excited to respond to anything that comes to Colorado. CMS is also working on a timeline that envisions all awards will be announced December 31st by the end of this month. So that will be the award at the state level. And we anticipate that the funding will be released to states shortly thereafter, although that timeline is not yet exactly determined. We'll talk more about the funding distribution once Colorado receives the award and the process by which those dollars will get out the door here in just a few moments. Next slide, please. A few other considerations. So post-award information and a little bit of what CMS has established in terms of expectations and allowances. First of all, CMS is not allowing any changes to the application post-submission, and they're also not going to allow any appeals once they've announced those awards. Cami talked a little bit about the fact that we'll have a designated team member from CMS who will monitor progress for the entire duration of the grant, and that will be entering into a cooperative agreement with CMS. And a cooperative agreement sometimes takes on a little bit different characteristics than other grant sources do sometimes. So for instance, we anticipate through our cooperative agreement that CMS will have significant involvement from CMS, the states, and CMS. We anticipate that they'll be participating in monitoring activities, reviewing all those progress and milestone checks, performance measures, and really getting involved in renewing funding allocations as well. So we'll know that CMS will be active in each portion of our program, and they'll ensure that we're meeting all the requirements required, that funds are being spent appropriately. So Kim just talked about how important it will be to make sure that everything is in tip-top shape, which Colorado is excellent at. The last thing here, again, just a reiteration, I know it's been stated before, there will be no rollover funds. So though all of the funding that gets distributed to the states must be spent within each federal fiscal year period. We'll talk just a little bit more about what that looks like here in just a moment. Next slide, please. Thank you. I'll turn it over to Cami now to talk about Colorado's post-award process.
Thank you, Laura. Yeah, so there's a lot of information that has been given today. So now we're going to talk about what it will look like once we're awarded. So next slide. So here is a rough timeline that we have. Again, a lot of this is going to be dependent on CMS. So we do know award announcements will come out December 31st. CMS has stated fund distribution will occur early in 2026, so we're anticipating January. Before any funds can be distributed out by states, we have to meet with our assigned CMS team member and also enter into that cooperative agreement, which we don't know what those details look like just yet. We also have to negotiate the funding distribution with CMS. Again, that amount is unknown. And we also will need to negotiate the program implementation timeline, as I highlighted earlier this morning. So there's quite a bit that we still need to discuss with CMS before we can even move forward with funding distribution to eligible providers. So any decisions on funding distribution and timing really cannot be made until Colorado meets with CMS and that cooperative agreement is final. One area I do want to highlight is funding for the first year. So we get a little bit longer timeline for this first year, I believe, to allow for those negotiations and that cooperative agreement finalization. So you'll see that December 31st through for 2025 through September 30th of 2027. So it's a little bit longer than we will have for other years in the program. So we do have a bit more time there. All right, next slide. Right, so what is Colorado's process for funding distribution? Again, this is to be determined based on CMS. We're really at their mercy. And I will say that, each time, because we really don't know what CMS is going to require from us. We don't even know what our annual reporting is going to look like until they send that over to us. So what we're looking at following is really a three-step process for awarding funds. the first step here on the left in yellow, we have our eligible providers and interested parties here will submit an intent to apply. So we are going to provide that when it's available. It's in development now. This is really just to offer HICPUF an idea of where funding is potentially going to be the most needed. So this gives us an idea. So when we go into some of those negotiations with CMS, we know what Colorado, the rural and frontier areas are really needing here. It in no way is going to lock you into that decision. It just gives us an idea and allows us to prepare for the next step. So here in the middle in blue, we have the request for application. So the same parties who are eligible to apply, and we'll provide this information later at a later date, not this morning. So again, we will have an RHTP funding request for application. It will be in an easy to understand, easy to submit format with more information to come here once that is developed out. Then we'll move into the next step, which is here in green, evaluation and award. So HICPUF, so one thing I do want to highlight, I do say HICPUF here quite a bit. It is a requirement that each state designates a department, a state department to receive the funds and distribute and really manage every portion of this grant. And so Governor Polis did appoint healthcare policy and financing as that department. So you'll see that throughout. So as we move on, so HICPUF will evaluate applications and award based on the requirements and approved funding distribution. So this is going to be important. The state is going to be held accountable to CMS every step of the way, and we have to stay in compliance. So when we do say things like based on requirements and approved funding distribution, that is those requirements and approved funding distribution based on CMS's approval of those items. So that is very important to note. Right, next slide. So our advisory committee, so there's been a lot of questions here. We are going to have an advisory committee. It's going to be very important to us. We're in the process of creating the committee. It will provide, those on the committee will provide advice, guidance, oversight over RHTP for the funding portion. We do intend to have a committee representative of all key stakeholders, and those can include provider associations, consumer advocates, and state agencies. These meetings are going to be open to the public, and we do expect to announce the advisory committee early in the new year. Some other areas that you can see the advisory committee will advise on, implementation and management of the RHTP program. So again, per CMS's approval there, potential funding distribution, and then the reviews of the applications and the requirements there. So for more information, we'll provide these links here. We will have that on our Colorado's RHTP website, along with other valuable information that I encourage everybody to check out. Oh, yes, and you can find that in the chat. Thank you so much. All right, next slide. All right, so continue stakeholder engagement. We're going to conduct a poll here really quickly. You can see that pop up on your screen. This is really open-ended. Stakeholder engagement is very important to us as we move forward, and us being all of Colorado, HICPUF, the Colorado Rural Health Center, everybody who is involved every step of the way. We really want to have, open, continued stakeholder engagement. It's very important for us. So we will continue to host community listening sessions, public comment opportunities. We want to incorporate feedback as we go. It's important for us. We will maintain our dedicated webpage. We do have weekly newsletters, and you can sign up for those on our website. If you scroll all the way down at the bottom, please subscribe there. Any new information that we receive or any updates will be provided there and on our website. We also have a dedicated inbox for any comments, questions, suggestions, all of that. But what really is going to help us shape as we move forward here, we want to hear from everybody. What are the areas that we should discuss? Where should we focus? What should we talk about next? So please, take the time to provide that information to us now. This is not your only opportunity. It's just a good one.
Okay, why don't we go to the next slide?
All right. So next step. So we have several next steps. Updates, again, are going to be shared within our newsletter and on our website. So be sure to sign up and check that often. Bookmark it. As we know more from CMS, we will let everybody know kind of our progress as we go. Again, we do have our dedicated inbox. Please send any questions there. And again, thank you for all of your engagement and participation. Colorado, we are a strong state. We have a strong application. We're very excited for the next step. And we just really appreciate this opportunity to make the meaningful impacts for Colorado's rural and frontier communities. So thank you so much. And I'm going to pass it over to Kim.
Thanks, Cami. Let's go to the next slide. And we're going to start our question and answer portion. We're exactly on time. We'll have about 20 minutes for this and then some closing comments. So Kelly, let's pull down the questions slide and put us in a checkerboard with all of the panelists. And I've got the list of questions here, and I will apologize up front when we have some 1,300 folks that register and 800 of them that are on at any one time, which means others might be coming on and off with conflicts, etc. We're not going to be able to get to every question, but again, it'll help us inform the next webinar, whether that's in January or whenever it makes sense, based on what Cami just said, your input in the poll that you just completed. And the questions that you're submitting now will help us guide the future engagements that we have. So first question, can you explain a sentence or two on what is meant by scope of practice in the state policy action section of the application? And Laura, I'm going to throw that one to you.
Yes, thanks, Kim. Happy to answer that question. So CMS is looking, when they're talking about scope of practice, they're looking at different categories of healthcare providers, licensed healthcare providers in Colorado, and they're looking at those different licensing regulations as it pertains to things like supervision requirements, continuing education requirements, and other components. And there are several third-party reports looking at every state and looking at all of the laws and regulations and rules around those scope of practice limitations and evaluating states against each other. It's good news, I will say, for Colorado. We scored the highest number of points there based on our current scope of practice regulations. Great question. Thank you.
Thank you, Laura. I'll invite Michelle or Cami to answer this one. If our hospital isn't a critical access hospital or sole community provider, how do we know if we qualify and can apply for the grant dollars?
Yeah, all rural hospitals qualify. So all 43 of you qualify because you're in a rural community.
Excellent news. Okay, next one. Would initiatives with a mental health or behavioral health focus be considered? Cam, you want to take that, or Michelle, do you want to take that because the coverage of who's eligible? Cami?
Yes. So we will have a full list of who's eligible later on. We are focusing on what CMS is allowing as well. But yes, those behavioral health, those others that have been listed will be eligible. Again, we do have some limitations there, so more information to come when we get to that stage.
think they also focused on community mental health centers versus independent behavioral health providers.
Yes.
Just to clarify the big bucket of what they're looking for. Next question. How will you choose which hospitals, clinics, FQs will receive funding? Michelle, why don't you take that very fun question?
Yes, that's a very fun question. So that is what the advisory committee is going to be working on, is the actual criteria for who gets what amount of funding.
Michelle, you might want to keep this or throw it over to Cami or Laura, but what are the limits of provider funding? Is that only for employed physician groups?
I will definitely toss that to one of you.
Yeah, so again, that's what we're going to work on with the advisory committee as we go forward. We also don't know the funding amount yet, so we do really need that vital piece of information to even know what the distribution is going to look like. So there will be some items like this, the distribution, who's eligible as we move forward, and what those restrictions might be. So again, more information to come as we move forward in this process and post-award and what that's going to look like.
Next, folks are asking for clarification. Do the page numbers on the pages where we're talking about the initiatives, do they reflect the narrative in the application? The answer is yes. So Cami said it was posted to our website, the Rural Health Transformation website that HCPF is hosting, but it's also right in the chat. So the application right there in the name of the document that you can go in there, and when we send out this presentation slides are also in the chat. You can match up the two. So if you are very interested in an initiative and you want to read more, you can go right into that application and refer to that page. Next, to strengthen rural healthcare delivery, transportation is very important to dialysis clinics. Dialysis clinics or transportation to dialysis treatments be part of the initiative, and I'll throw that over to Laura.
Yeah, excellent question. I think as part of any of the initiatives that think about, increasing access and sustainable access to healthcare, lots of different types of initiatives will be considered again within those boundaries that CMS allows. So we'll encourage folks to keep their eyes peeled and think about how we can improve that access.
Laura, I'm going to keep you on the mic here and ask you to just talk a little bit to how does telehealth investments or telehealth overall play into the opportunities that the Rural Health Transformation program provides. So relative to clinic service lines or relative to maternity care, relative to long-term solutions.
Yes, happy to answer that question. So in terms of the CMS goal that's related to technology innovation, and some of the other access components as well. We know that telehealth is one model. We think about the e-consults model here in Colorado. That is a potential for investment. And at the same time, we'll acknowledge, and I think this was covered in the application too, that growing, that local workforce, sort of those in-person services is also important. So there is a balance in the application, both in expanding telehealth and technology-driven services and supports, as well as making sure that workforce development happens in local communities as well.
Thank you, Laura. Cami, I want to throw this one to you. Can you address just behavioral health in general and how the BHA might engage in this work overall? And then specifically, how will this initiative work with the training available for the workforce on the BHA's OwnPath site? So I don't know if you can get that specific, but maybe start at the high level. How might the BHA engage in this work?
Yeah, so behavioral health is going to be very important as we move forward. So not only are we working with the Office of eHealth Innovation, we are also working with the BHA as we move forward with these initiatives for behavioral health. So that is actually highlighted. CMS is definitely looking for that. Not only that, Colorado needs this. This is an area of great opportunity and support that we can provide here. So where we're able to support those initiatives and provide those sort of collaborative, connections there, that's going to provide the care coordination that's needed for those patients as we're looking for those initiatives and growth there. Those opportunities are available, and we are going to be working closely with that agency as we move forward in those initiatives.
Thank you. Laura, I'll throw this one to you. Relative to workforce development, was there any attention paid to the development of school nurses or community health workers as part of the workforce potential for development?
Yeah, excellent question. The short answer is yes. So you'll see in our application components, there are several different types of health workers identified. The short answer is looking for any and all opportunity to really improve outcomes and access. We know that sometimes there are different fields and professions and relationships in the medical and clinical professions that matter most in rural and frontier communities. So short answer is yes. And again, all in compliance with those CMS requirements about who can actually receive the funding. Great question.
Thank you. Cami, I'm going to give this to you and then invite Michelle to maybe add some color here. The overall question is about regional health networks. How do they expand access to care? If the organization is it within a health system that we're talking about? So I'm gonna correct myself, and I'm gonna answer a little bit of this. So again, the question is regional health networks. What do we mean by that? How do they expand access to care? And how are providers a part of that? Are they saying that you have to be part of some big system? And so I'm going to just start. You'll watch the state try to find efficiencies. We started talking with rural hospital leadership back in April about how we might be able to have efficiencies for rural hospitals who have the highest administration costs and often struggle to do all the things they want to do because they don't have as much revenue coming in that other big systems do. So we've been talking with rural hospitals about how do you share some of the resources? How do you have partnerships in a different way? So is it possible that you share an HR resource that helps you recruit and train, which is so important? Is it possible that you share some of the billing and revenue cycle, which is also really critical? Is it possible that you share resources that might help you handle the utilization management requirements that you have for commercial and Medicaid and Medicare? Is it possible that you share nurses so that you can be one big ACO, accountable care organization, and share in value-based payments because you've built an infrastructure that you all share? And so I'll start with that, and then I'll turn it over to Cami to add some color to what I said and Michelle to add. This is one of the most important things that CMS is focused on. How do we handle rural capacity differently, given that there's less volume and so much overhead? How do we do this differently? So go ahead, Cami, and then Michelle.
Yeah, I'll just second what you stated. We're really looking at being very collaborative. So, folks, if you're in the same region, hospitals, clinics, FQs, all those eligible providers, we really got to work together. That's how we're going to be able to be sustainable, because keep in mind, these grant funds are going to end. So we need to have a way that we can work together, share those resources, be creative in this space, so we can continue the great work that we need to do. So yes, you'll see all of that, being supported. We do really want to encourage those, fostering those collaborative, networks. Again, doesn't have to be the tech side, but it could be the tech side. Really working together, job sharing, or, looking at those resources that may be in abundance in one area, and can be shared services for another, and really support patients across the state. So we're looking at really being able to develop those networks that you have. So it's not just hospitals only working together, clinics only working together, but really all of you working, as a core group and developing that out. So we're really going to be encouraging that as we go. So, Michelle, I don't know if you have anything more to add there.
Yeah, I would just add, being mindful that, we want our rural communities, through regionalization to be able to maintain their independence. And so this is not saying we're forming a new entity like a big, system that we find here in town. So it is maintaining that independence. But one thing comes to mind for me, we've had a lot of rural hospitals have to close OB. And so that is a perfect opportunity to take that problem and how might we resolve that, on a regional level to maybe say, one of our hospitals is going to, do the OB care for 2, 3, 4 communities type of a thing. But how do we debundle the payment, which is a policy opportunity to say that, our primary care providers in our local community provide that prenatal care. So just another opportunity.
And I would add, we've been talking about how do we make sure that the rural hospitals and the rural health clinics that are often owned by the rural hospitals and the independents can really step into that ACO environment and have contracts with Medicare Advantage programs, have contracts with Medicaid to get attribution payments for our Medicaid care management functions and work more closely with the RAIs. And how can they have relationships and better contracts with commercial payers? Because they've got the engagements and the tools and the contracts to do that. And the Rural Health Center in HCPF actually worked on a budget request from HCPF a couple of years ago. And you might remember 11 million coming out of the General Assembly. It's actually 30 million in the governor's budget. We get 11 million out of the General Assembly to try to get the resources around that. And we ended up having really good access and affordability grant applications that came in, and we did a good job working in partnership, similar to how this is going to work, and distributed those grant dollars. But we didn't get the applications that came in for that work, that really important work. So with the regional accountable entities, we actually put that as a mandate into their contracts that they had to provide you with the tools as rural primary care providers in order to do that. So we have an infrastructure now where in this case, it's largely Rocky Mountain Health Plans backed by United Healthcare, but it's really Rocky's tools that they've been using for years successfully with providers that they're required to work with our rural hospitals and rural clinics and rural independent providers at no cost to provide that. So we have this opportunity to actually put that on steroids. We can figure out how do we staff that? How do we achieve the attention of that now with the tools that it can actually come through the RAI? But how do we figure that out? So I think there's huge opportunity, and we really have to figure out how do we transform, and that will also be, what does CMS want states to do, and how do they step up, and what are the thoughts of the rural providers and the Rural Health Center, and how do we get to that utopia, which would bring sustainability, which is really about what a lot of this is. So we're all excited about that. Okay, Michelle, I'm gonna throw this over to you. Is there any indication of what is meant by approved states for the 50-50, that what will be distributed equally among the providers?
Yeah, for sure. So approved, like I said, is kind of that key word, meaning that you can't just submit a really bad application that doesn't meet the requirements. And so if your application doesn't meet the requirements, you will not be considered within that distribution piece.
Thank you, Michelle. Cami, I'm going to throw this one to you. Will there be space to pilot and test technology innovations built specifically for rural communities? A lot of the current tech is not built for our rural communities.
So yes, absolutely. We do have areas where we can be creative in our technology space, our innovative care space as well. So be thinking about what your needs are if you're an eligible provider and about to apply for grant funds. But do keep in mind any technology or anything supported here that we have outlined, we have to be able to sustain it. So any plan that does come in, as we're reviewing, we have to be accountable to CMS there and be able to sustain it when these funds do end. But we do have potential here. Again, we're going to have limitations and restrictions, the long list that CMS provided. So we will have to stay within those bounds.
Thank you, Cami. Okay, the next one, will CMS approve a portion of the Colorado application budget, or is it an all or none approval? i.e., is it possible for Colorado to be awarded less than the application budget, or is it possible that Colorado will get no funding? I'll start on that, and then Laura, I'll ask you to chime in. But when I went over the budget and I said the template added up to $1 billion, 200 million each of 5 years, that was the template that everybody needed to fill out. And I'm suggesting that we do not rely and assume we're going to get $200 million a year and $1 billion over 5 years. That would be, wow, right? We should all do cartwheels if that comes to play. I would say if we were a gambling organization, which we're not, we're conservative hick puff here, waiting for the data, the answers, the verified answers, we can pretty surely rely on the $100 million a year because we submitted a qualified application. We worked really hard to make sure that was qualified. And then how much of the rest of that, that's going to be hard to guess. And I'm going to change my mind. Michelle, can you make some comments and then we'll go over to Laura and Cami to add anything additional?
Yeah, I think that, the second portion of that funding is really where the big questions lie because they say it's going to be based on rurality and based on where facilities sit. We've been so fortunate to not have any rural hospitals close in, I don't know, decades type of a thing. I don't even remember when a rural hospital closed. But we have folks down in the South, that do have a lot of rural closures. And so I suspect they will likely get a good portion of that funding.
Cami, Laura, anything to add?
Yeah, I'll just add one more piece of information, and that is it possible that Colorado will get less? Is it possible that Colorado will get none? I think at this point, CMS, anything is possible. And one thing to consider, and I agree, Colorado submitted a really competitive application. They'll be reviewing and scoring based on this algorithm, this formula that looks at all of those data factors, Michelle, that you just listed, and then some very subjective scoring factors. That they're doing this sort of proportionality against every other state, which makes trying to estimate how much of that potential billion-dollar template will come to Colorado very challenging. So we're optimistic and confident in what Colorado submitted, and we'll look forward and know that CMS will see that too.
Thank you, Laura. And I'm going to pull us into closing comments, just looking at the clock here. So I'll start and then I'll turn it over to Michelle. Thank you for your time today. Thank you for your engagement. Thank you for filling out the poll because it'll help us inform our next round of webinars, stakeholdering conversation. That's really important. Thank you for your grace. We're all in something that, once again, it's a little bit uncharted on how we're doing this, but we all have one very shared goal: bring as much money home as we can to help our rural partners. And in that, I want to end with thanking Michelle for her tremendous leadership. As I thank all of you, thank you, Michelle, for your tremendous leadership. And with your national hat, your expertise, your seasoned leadership for so many years, your absolute understanding with your team, your expert team behind you of the rural communities and everybody else that's putting time into this. And thank you, everybody, for your future efforts with us as well. Michelle?
Yeah, thank you so much, Kim. And I just want to do a huge shout out to my team, to Cami, to you, to everybody on your team. We know that there's really tough times ahead for rural, and we're very hopeful that this funding is going to come through and really help us, transform and sustain access to care in our rural communities. And most importantly, I want to thank all of you for spending your time with us and for your patience as we navigate through this process and continue to communicate with us. So thanks again.
Well, have a wonderful day. Happy holidays.